Good afternoon, everyone. It's past noon, so we'll get started. Welcome to Medical Grand Rounds. Just a reminder, we'll ask you to please enter your questions in the chat at the end of the presentation. As well, please answer a brief survey that will let us know that you were present at today's rounds. Before we introduce our speaker, I'd like to make a brief land acknowledgement. McGill is on land which has served as a site of meeting and exchange amongst Indigenous peoples. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which peoples of the world now gather. So this afternoon, I would like Dr. George Fantis, who's the Chief of the Division of Endocrinology, to introduce our speaker, who was invited by the Division of Endocrinology. So George, floor is yours.
Thanks, Nadia. Welcome, everybody, to Medical Grand Rounds today. It's a special Grand Rounds. This is the McGill Novo Nordisk Lecture. So it's a pleasure for me to introduce this year's 39th McGill Novo Nordisk Lecture. Before I do that, I must thank Novo Nordisk for their support of this lectureship award, which is, as I mentioned, now in its 39th year. This allows the Division of Endocrinology and Metabolism to host internationally recognized physicians and scientists to share their knowledge with the entire Department of Medicine and meet with faculty. Special thanks to those on the Zoom: Novo Angel Ong, our Medical Sciences Liaison; Alain Sad, Senior Director of Regional Sales; Bernard Boivin, District Business Manager; and of course, Anna Furci, our hospital rep. This year's awardee, Dr. Mark Donath, of 2023, is Professor of Endocrinology at the University of Basel in Switzerland. He's Director of the Division of Endocrinology and Metabolism and also serves as Dean of Research at the university. Dr. Donath completed his MD in Zurich Medical School, followed immediately by a research fellowship at the Institute for Cell Biology at the Swiss Federal Institute of Technology, also in Zurich. He returned to clinical training in internal medicine and then did subspecialty training in endocrinology and metabolism at Hadassah Hospital in Jerusalem. Following this, he returned to the University of Zurich to begin his independent research career. His research led to groundbreaking discoveries into the role of inflammation in beta cell dysfunction, leading to type 2 diabetes, specifically demonstrating the action of interleukin-1 beta that led to the first clinical trial using an IL-1 beta receptor antagonist in type 2 diabetes that was published in the New England Journal. In 2010, Dr. Donath was recruited to the University of Basel and went on to demonstrate the mechanisms of IL-6 and IL-33 in the regulation of insulin secretion and discovered a novel form of monogenic type 1 diabetes. His work has received international recognition and selected by Nature as a milestone in diabetes research. Dr. Donath, of course, is in demand as a grant reviewer, speaker, and serves on multiple editorial boards, and at the same time continues to teach and mentor trainees. It's with great pleasure that we welcome Dr. Donath to McGill to deliver the 2023 Novo Nordisk Lecture on the role of inflammation in diabetes and its complications, pathophysiology, and treatment. Mark, welcome.
Thank you very much for this kind introduction. I'm going to share my screen. Do you see it correctly on Zoom? Okay. So my pleasure to be here. Is it fine? Yeah, okay. And I hope you can all hear me well. What I'm going to do today is first to give 2 or 3 minutes of preclinical background, and then is everything fine?
Just going to make this screen.
I am on full screen, so it's just the wrong screen, I guess. So probably I have to stop share. And then probably have to keep this one. I think we have to share the other screen.
This one.
No, this one.
No, it's this one.
There you go. That's
Okay.
enough.
Is it fine? Okay. So I'll start with some preclinical data, and then the rest, almost the whole rest of the talk will be clinical, but more than going to details, what my aim is more to show a little bit of principle of what we today call immunometabolism. I will do that by the angle of my research, but I guess that it is a little bit of general concepts. So we started with, is it okay?
Just 1 second, please. Sorry about that.
So I think I have to do it like that. May I do it?
Yeah, stop sharing.
Then first give it like that, and then share.
Share.
This one.
Yeah,
wait,
select the one that's full.
well, that's this one, I guess.
This
See?
one here.
It's not the right one.
No,
So let me.
share. Share.
Share.
Celui-là.
Celui-là.
There you go.
It's fine?
Yeah.
Okay. So that's how we started. Quite naively, we were trying to understand the toxic effect of glucose in human islets is a specific setting, but that is where we see this interaction between metabolism and the immune system. And more specifically, there was just very simply, if you increase the concentration of glucose to human islets, then you induce the production of a cytokine IL-1 beta. And just to say, at that time, there was really no much connections between the two systems, and that was a little bit a surprise. And therefore, we went on with this observation in animals. And what we used is a very...
It's not advancing.
Oh, it's not advancing, then it have...
That's what announced it.
Okay, I guess we didn't have enough long COVID, so I'm not sufficiently trained. Anyway, so we use for that an animal models of diabetes, which, by the way, I think is the best animal. It's just a problem because it's a gerbil, so it has different genes, but it's really similar to the human diabetes. When it's in nature, it live healthy, and if you expose this animal to high-fat diet, then very rapidly develops a real diabetes, not like mouse, which have more impaired glucose tolerance. These develop a huge diabetes with also complication of diabetes. And what we did with this animal is we put it on a high-fat diet, and then we observed that there is induction of IL-1 beta, so inflammation in the pancreatic islets that you see here in tissue sections. And then we used an SGLT inhibitor. It was almost 20 years ago. So we didn't realize at time that this will turn out to be drugs, but we use it as a tool to induce glucosuria and so to normalize glucose and to prove in vivo that if you decrease the concentration of glucose, you prevent the induction of these inflammatory cytokine IL-1 beta, proving in vivo that glucose induces IL-1 beta. So we had on that glucose or metabolic stress induces IL-1 beta, and you can prevent that in by inducing glucosuria. And I will come back at the end of the talk a little bit about the SGLT2 inhibitors. And we believe that it has to do, they're working also with inflammation. But the more general concept, and in the meantime, many others has shown in parallel to that to us that not only glucose, but also lipids, uric acid, and also some bacteria, all of what we would call a metabolic stress induces then reactive oxygen species, which then will activate the inflammasome, and this inflammasome will activate IL-1 beta. And the concept that I like to promote here is that this inflammasome seems to be a sensor of metabolic disturbance, depending on whatever context it is. So it can be in the blood vessels, then it's cholesterol that will activate the inflammasome and inducing IL-1 beta. It can be in the fat tissue, then more lipids, can be more in the beta cells, and probably the dominant factors is glucose. It can be also like in gout arthritis, or in and then it's uric acid, or if you have bacterial leakiness like you have in obesity. All of that will be sensed by the inflammasome, and that will lead to IL-1 beta. And based on this finding, at that time we didn't have this whole mechanism, but still we went on by trying to see if this is just something in vitro or in animals, or if it has clinical relevance. And we did an initial proof of concept study where we antagonized the IL-1 system using the interleukin-1 receptor antagonist, and we could show that by this pure immune modulation, we can improve glycemia. And I think it was the first time that really this connection was shown, and by doing so, we improved HbA1c. But, and that was for our hypothesis more important, we also, this was achieved by improving insulin secretion. I will not go here into details, but by many means, we show that insulin secretion is improved. And what interested a lot the cardiologist is that CRP is decreased when you antagonize the IL-1 system. And that interested in particular Paul Ridker, who showed that CRP correlates with cardiovascular disease. And here we could show that we can decrease this biomarker of inflammation by antagonizing the IL-1 system. In the meantime, we and others have conducted several other studies antagonizing the IL-1 system, and I believe that it is now quite robust data showing that if you antagonize the IL-1 system, you can improve glycemia. But as you know, it's not sufficient to improve glycemia. If you want to introduce a drug to the market, you have to show hard endpoints nowadays. And therefore, I'll show you a little bit where the field is now going. On the one hand, we're looking at complication of diabetes. And there has been a preliminary study. It's a small study, but still they antagonize the IL-1 system here with an antibody to IL-1 beta, canakinumab, and seem to have beneficial effect in retinopathy, in parallel to improving glycemia. And another study looked at association between diabetes and other disease. And as you know, and I like the concept of metabolic syndrome. This whole metabolic syndrome is associated with several diseases. And one of them is, of course, gout arthritis. And as I've said before, the uric acid is also inducing the inflammasome, and and probably there is nothing better to stop an acute gout arthritis, or also a chronic one, than antagonizing the IL-1 system. It's very efficient, and if you do so, you do not have the effect in patients with type 2 diabetes that you don't like, which is increasing glycemia. So you do two things by antagonizing the IL-1 system in patients with type 2 diabetes and gout arthritis. And this was shown in this preliminary study and has been repeatedly shown by the other study. And I have to say that in some cases, we also do it already in the routine, that instead of giving steroids in patients with rheumatoid arthritis and diabetes, we antagonize the IL-1 system. And following what I've said before, that IL-1 blocks CRP, and the cardiologist, independently of us, had shown that cholesterol induces also the inflammasome, and that led to the study that you've certainly followed, which was the Cantor study, there with an antibody every 3 months antagonizing IL-1 beta. The outcome was cardiovascular endpoint, and it was statistically significantly achieved. And within that study, we had also a chance to look at different things. One of them is heart failure, and that was not a predefined analysis, but still quite clearly it was also an improvement of heart failure. Regarding diabetes, I have always to say it was not a diabetes study, so the only a part of the population had diabetes, a part of the population had pre-diabetes, but still we had a look at that. And for around 2.5 years, it was predefined in the analysis. There was a significant prevention of diabetes. In fact, also it was not predefined, but still for 4 years, there was a prevention of diabetes, and then the effect was lost, but also most of the patient was lost. But still, as a concept, I think it supports the concept. And also in this population, in the diabetic population, there was an improvement in A1C for the first months, and then the anti-diabetic drug was adapted so that you couldn't see the effect anymore. But in the non-diabetic one, over all the time, they had in this pre-diabetic population lower glycemia. So it's a little bit technical detail, but it supports the concept that antagonizing the IL-1 system, you can improve diabetes. And the last clinical study in this context that I want to show you is a very important one, I think, because it has several concepts in it, which was conducted in Italy. And they compared in patients with rheumatoid arthritis anti-TNF with anti-IL-1 beta inhibition. And usually, as you probably know, anti-IL-1 beta in patients with rheumatoid arthritis is not very efficient, and anti-TNF is much more efficient. But in this patient population, first of all, diabetes strongly improved. There was a strong improvement in A1C in the patient treated with the IL-1 receptor antagonist, while the anti-TNF didn't change much. And if you looked at the rheumatoid arthritis specific endpoints, then in this case, an IL-1 antagonism was at least as efficient, numerically, in fact, more efficient than anti-TNF, meaning that if both disease comes together, then you have a kind of potentiation of this inflammation, and you are much more efficient if you tackle the specific cytokine. And I think it's a little bit the direction that we will have in this concept of immuno-metabolism, that we are not going to follow so much specifically a disease, but more looking is what is driving the disease. Is it a TNF disease? It's an IL-1 disease. And depending on that, you will see a little bit more of this of glycemia problem, or a little bit of one of the specific feature of this disease. So if I'm summarizing this part of the presentation, if you antagonize the IL-1 system, and this is based on clinical studies, you can improve cardiovascular complication, you can improve heart failure, glycemia, you can improve beta cell function, can improve also associated disease like gout, arthritis. I didn't show you the data on cancer, but there is also several studies showing that you can improve also cancer. The nice thing in this approach is because you're impacting in the pathogenesis of the disease, you don't see hypoglycemia. And where the field is going now is also looking at several other endpoints, and one of them will certainly interest, George, because you're interested in kidney. So there will be studies on kidney and other part of the metabolic disease. Now, the limitation and the side effects, I have to say, overall, we were surprised and pleased to see that we see very, very little side effect. And in the largest study, which was a counter study, the only real problematic side effect was in severe infection. People on ICU, there the mortality was increased if the IL-1 system was antagonized. But two things to say to that. First of all, probably the level of infection was underestimated because you decrease CRP. So probably people didn't realize the severity of the infection. And that's something you have to be aware that the CRP that you monitor typically for infection may not be a reliable biomarker of your level of infection. And the second thing is you use antibodies, and of course, you can't stop them. They have a very long half-life. But the field is going more to shorter inhibitors, and I say a word briefly on that. But if I would summarize what I've said until now, then we have this metabolic stress, which is sensed by this inflammasome via reactive oxygen species. And then you have IL-1 beta leading to all these complications, and also possibly here we don't have clinical data, but possibly also neuroinflammation associated with Alzheimer and other neurodegenerative disease may also be driven by this pathway. Now, I'm focusing, and sometimes people said I'm a little bit narrow-minded, and they are certainly correct, that I'm always looking at IL-1 beta, and certainly IL-1 beta is a very important cytokine in this context. But of course, there are other cytokines, and there are a lot more to learn. And here we try to summarize the different cytokines where there are direct or indirect evidence. And in red is the one which are validated by clinical studies. Other one are on the investigation. But just to people give a sense that it is certainly not just, it would be naive to say that all immunometabolism is limited to IL-1 beta. But where we are going and the field is going with IL-1 antagonism is with NALP3 inhibitors. And it's a Novo Nordisk supported lecture. So I just want to say one thing about Novo Nordisk. They recently acquired a NALP3 inhibitor. And so obviously they also enter into the field. But the most advanced NLRP3 inhibitor is from a small biotech, Olatech. And they have one very specific, which doesn't prevent the assembly of the NALP3, not the enzymatic part, but it comes to the same. So you cannot produce maturate IL-1 beta. And this inhibitor is now in phase 2. And within the phase 1 and 1b, there was a clinical study on heart failure. And it showed promising results in preventing heart failure. And with that, we looked at glycemia, and also it's a small population, but we saw quite encouraging result there. And now we will have, for us, quite a large study. And it's the plan is the first of 2 studies to introduce that into the clinic, where we will treat for six months with this NALP3 inhibitor, dapagliflozin, in a diabetic patient population, 2-to-1 randomization, double blind and everything. And this study will be supported by a funding from the European Union and by the Switzerland. And the company will provide us this drug. So this is what we are now mainly working on, and of course we are quite excited by the study. The primary endpoint will be A1C, but we will look at complication of diabetes with some focus, including kidney, but also neuropathy and also cardiovascular. Also, we don't expect endpoints there in cardiovascular, but biomarkers. Now, let me switch a little bit to what is scientifically more interesting us currently, and then I will come back at the end to give a little bit a broader picture of everything. And the question that we have is, I've mentioned now to you the deleterious effect of the IL-1 system. And I've shown to you how the NAD3 is sensing metabolic changes, and that cannot be that it is just something deleterious. It must have a physiological role. And this is what we are currently investigating. And let me give you again 5 minutes of preclinical data, and then we go back to the clinic. And what we did in the lab is a very simple experiment of acute feeding experiment. So we take the mouse, fast them overnight, and then acutely expose them to food. And then acutely, you have an increase in IL-1 beta. So in absolute number, it's a very low increase of IL-1 beta, but it's highly reproducible and statistically significant. And by the way, we observe the same in humans. So each time that you eat, you have an increased level of IL-1 beta. And then what is this IL-1 beta doing? One of the things that it seems to do is to induce insulin secretion, because if you don't have this acute increase in IL-1 beta, like you have in knockout mouse, then you have about 1/3 less of insulin. And that translates also in changes in glycemia. And that was a little bit of a surprise for us, that is bad IL-1 beta suddenly stimulate insulin secretion. And therefore, we conducted an experiment where we directly injected IL-1 beta to mice. And you see here, we inject IL-1 beta, and there we see a little bit of increase of insulin. Then we come with the glucose, and then the glucose-induced insulin secretion is strongly potentiated. And this kind of experiment are very standard in the lab, and we do that for 15 years. And I can tell you that we never had something which is so much potentiating glucose-induced insulin secretion. If you take, for example, a GLP-1 analogs, you will be here around at max and never as strongly as that. So we have glucose induces IL-1 beta, and without going more into detail to this study, because it's already also published, but our working hypothesis on that is conceptually, when you eat, then the body has to handle, in fact, two things. On the one hand, it has to handle nutrient, but on the other hand, each time that you eat, it's a time where bacteria and microorganisms can enter into the body. And then it's critical that the energy is allocated appropriately. And what people tend to forget is that to mount an immune response, you need a lot of energy. That is something you can very simply observe. If you do a PET scan, then you see that the glucose is going where the immune cells are, and that shows you how much energy the immune cells need. And our hypothesis is that the IL-1 system works together with the endocrine system, the insulin, and depending on how many microorganisms you will have more or less of IL-1 beta, and that will work together in order to direct then the glucose to the different tissues. So if it's more of pure glucose without microorganisms, you will have more insulin driving the glucose to fat or wherever they are needed. It can be also muscle. And if there is more microorganism, then you will have this potentiation of the IL-1 system and IL-1 beta. I didn't show you your that here, but is also inducing glucose uptake in immune cells. So this is a little bit the concept, and just to give you an example how that occur in real life, if I may say, if you have a situation of starving, a lot of time you have a much more infection. And the reason why you have much more infection is not, as people believe often, of question of hygiene, is because to mount an immune response, you need a lot of energy. And if you have limited amount of food, the body will not afford an immune response. And to survive, the few calories that are around will be reserved to vital function like brain and heart, and the immune system will be in a way starving and cannot respond then to microorganisms, but at least the people survive. So this is a little bit this concept of physiology, how the two systems work together, and why possibly we have this immune metabolism. But to support that and to support these glucose inducing IL-1 beta, inducing insulin secretion, we wanted to show if this is something occurring really also in vivo in human. Now let me switch a little bit to something to show you how we tackled, how we tried to demonstrate that. And for that, we looked at something that you may be familiar with, which is the problematic of postprandial hypoglycemia after gastric bariatric surgery. And you may know that it's quite often occur. It's often not realized by the clinician because of this postprandial hypoglycemia occurring typically when people have lost quite a lot of weight around 1 year after surgery. Then the postprandial, quite a lot of patients, and it's estimated maybe about 30% of the patient have this hypoglycemia. And to compensate this hypoglycemia, they will eat more and regain weight. And that is possibly one of the mechanisms why there is a weight regain in this patient population, because you don't feel well, then you overeat if you have hypoglycemia. And what we hypothesize is the following. So we had the food intake. We believe that because of the anatomic change, there is an increased postprandial hypoglycemia. And the hypothesis is that this will then stimulate this IL-1 beta, leading to an exaggerated insulin secretion and eventually to hypoglycemia. And we tested this hypothesis at two levels. First of all, by using an SGLT2 inhibitor, so limiting the postprandial glucose uptake. And the second is by antagonizing the IL-1 system with anti-IL-1 receptor antagonist. And it was studied, so we had 3 days of investigation. 1 day SGLT2 inhibition, another one IL-1 receptor antagonist, and the third day it was double placebo, and everything crossover in this patient population. And I wouldn't show you the data if it didn't work. What we could show is by both approach, by antagonizing IL-1 receptor antagonist or by antagonizing the SGLT2 system, we had significantly less postprandial hypoglycemia. And we are so we can conclude that and I don't show you the data here, but we show really that also by inhibiting SGLT2 inhibition, with SGLT2 inhibition, we had less IL-1 beta secretion and so on. And so our conclusion for that is that post-bariatric surgery, glucose-induced IL-1 beta triggers insulin and hypoglycemia, and you can prevent that either by SGLT2 inhibition or by IL-1 beta inhibition. And we are now having ongoing 2 follow-up studies, one with an antibody to IL-1 beta for 1 month in this population, and the other one with empagliflozin in parallel. Also, and both studies are placebo-controlled the idea is to implement that into the clinic. But we already now have a few patients who were in the first study and they didn't want to enter the follow-up studies because they benefited acutely so much of it. And that's one of the examples, continuous glucose monitoring data. So that was a patient before treatment with repetitively problematic hypoglycemia and much of improvement after receiving empagliflozin. And this patient doesn't want to stop it anymore. He really suffered. He had to eat at least 8-9 times a day in order to prevent hypoglycemia. Now, the question is, how now do we reconcile the two things? On the one hand, I've told you that IL-1 beta is responsible for beta cell failure and for diabetes. And on the other hand, I show you that IL-1 beta is a secretagogue. And here comes a principle which was shown, I think, 30 or 40 years ago, which is very simple, but probably very accurate, that the problem of the beta cell in type 2 diabetes is probably largely not so much of primary impaired insulin secretion, but it's a continuously over secretion of insulin, in a kind of hyperinsulinemia, and certainly in early stage of diabetes. And this hyperinsulinemia, first of all, may also promote obesity, because if you have too much insulin, you have to eat more, but is also exhausting the beta cells. And the idea is a little bit like the beta blocker in heart failure, which is in a way counterintuitive. If you think heart failure, you give a beta blocker, but that restores a better function when the heart is really needed. And probably blocking IL-1 beta is inducing beta cell rest and thereby improving beta cell function. And the second beneficial effect of IL-1 blockade is to decrease tissue inflammation and the chronic inflammation, which eventually is always deleterious. And so putting that a little in a context, we would have the normal situation, and then we will have the prediabetes with increased IL-1 beta secretion and hyperinsulinemia promoting even more obesity. I'm not going here into the details, but amyloid deposit can also activate the IL-1 system. And then eventually you will have impaired insulin secretion after exhaustion of the beta cell and also tissue secretion, tissue destruction, and therefore insulin secretion defect. And to finish the last 5 minutes, I like to bring a little bit everything together and bring a little bit a different angle of the whole pathogenesis of diabetes. And I start with what as the endocrinologists were the big surprise is to realize that our patients with type 2 diabetes are dying of heart failure. And until the MUHC study, at least me, I didn't know anything anymore about heart failure. And really, we had to endocrinologist crash course in heart failure. And the reason for that is, as you know, that these SGLT2 inhibitors, which induce glucosuria, prevent this heart failure. And the question is, how does that work? And there is a lot of hypotheses, and I will present mine. And when I'm saying there is a lot of hypotheses, no one has proven one, and my one is also a hypothesis, but I like to bring it up. So the first point is that people underestimate how much glucose you lose with an SGLT2 inhibitor. So this is my cup of coffee. This is the sugar that you lose every day with an SGLT2 inhibitors. And the important point here, this occurs also in pre-diabetic patients with normal glycemia. And one of the things that often is said by cardiologists, that the whole beneficial effect on heart failure cannot have to do something with glucose urea induced by SGLT2 inhibitors, because HbA1c doesn't change. But it's not because HbA1c doesn't change that there is no change in where the glucose is going. And typically, in obese individuals, the glucose may remain in the body, but if you give an SGLT2 inhibitors, it will go into the urine. So you have this amount of glucose which is not staying into the body. The second thing is here you have a tissue culture of cardiomyocytes in culture that look a little bit different. It's not the point here, but you see these beautiful myofibrils, and these cells are in fact contracting. And if you expose them to glucose, after a few days, you have myofibril degenerations and apoptosis of the cells. And in fact, it's quite dramatic if you do this kind of experiment. And fortunately, in vivo, this doesn't occur. If you have hypoglycemia after a few days, the patient is fortunately not dead, he's still alive. And the reason is that there is a protective mechanism against this glucose toxicity. And this protective mechanism is insulin resistance. And I don't know how many of you are familiar with Mark Prentke, who is, I think, in a neighbor hospital. And he had a brilliant idea many years ago, and nobody took him seriously. I took it seriously, and I think that the brilliant things are often very simple. And he said something very simple. He said that insulin resistance is not something detrimental. It's a protective mechanism. It's a way the body protects you from overnutrition. And in fact, if you don't have insulin resistance, then you have more rapidly body weight increase, you have more rapidly NASH, and you have also more rapidly heart failure. And one of the proof of his hypothesis is very simple. If you take an insulin sensitizer, and you had one, I don't think you're using it anymore, we don't, that are the PPAR gamma agonists, the thiazolidinediones. And what is the side effect of these drugs? First of all, you put on weight. So in some patients, maybe it doesn't matter if they have 100 or 110 kilograms, but it's still something which is not what you want to achieve. So you improve glycemia, but it's a cost of that. But the second thing, one of the side effects of this drug is heart failure. And retrospectively, it's very simple. If you break the insulin resistance, you break the protection of the tissue, and then you have insulin and then you have heart failure. And therefore, the insulin sensitizer is not a good idea. And instead of insulin sensitizing, you may also give insulin. And we all know that if we start insulin, especially in obese individuals, we have the problem that the patient increase in body weight. But, and there are more and more indirect evidence for that, they may also be more inclined to heart failure. They may be more inclined to complication because you put the glucose where it is already toxic, and you increase this toxicity. And it's therefore much more elegant to not to charge to insulin resistant, leave it like it is, but try to get rid of the glucose via a natural way, which is the glucosuria, and you may promote it even more, and try not to increase also glycemia. And there is either you give an insulin or you give also sulfonylurea. And again, sulfonylurea, we all know that there is nothing more unfair to give an sulfonylurea to a patient and tell him now you have to lose weight. It's almost mission impossible. But on top of that, you may increase also his diabetic complication, and in particular heart failure. And again, the data is not closed, but there is a lot of indirect evidence. So try not to increase insulin, try to reduce it. And if we take now our work, that can be achieved with also anti-IL-1 to decrease the hypersecretion of insulin and try to get rid of the glucose. And in a way, and this is what I want to show you in this scheme, for many, many years, we as endocrinologists focused only on HbA1c. And that's where the glucose in the circulation is. But we don't have just to focus on the HbA1c. We have to think, where do we put the glucose. And that's the whole point. And if we put the glucose in this organ, we'll have a toxic effect. And if we trash it properly with glucosuria, then we get rid of the problem. So maybe the fish will become diabetics if the whole water is full of glucose, but we are rid of the problem. And if now and that is my last slide, put the whole thing in a big picture of how to treat basically the metabolic syndrome. Nobody will argue that the best way is, of course, to prevent overnutrition, to exercise, so that we can get rid in a proper way of overnutrition. If this is not achievable with simple lifestyle intervention, then the GLP-1 analogs are of great help. If you have the nutrient in the circulation, then try to get rid of it in a proper way. And that can be achieved with SGLT2 inhibition. And if it comes to the tissue, then you have the toxic effect of the nutrient. And here is where we see that modulation of the that this toxic effect is mediated, like most of the toxic effect, in a simple way by inflammation. And there is where we see the possibility of anti-inflammatory treatment. I hope I didn't confuse you too much and that it was clear with my hypothesis. Before giving opportunity to ask questions, I'd just like to acknowledge people of my group that contributed to the study that I've presented today. So thank you very much for your time.
Well, thank you very much, Mark. I think we'll go on. We have a few minutes for questions. So if there are any questions from the audience here, and then we'll repeat the question for those on the Zoom. Nadia?
Thank you. Fascinating lecture. Thank you so much. So, just thinking about your last couple of slides, the hemoglobin A1C, just measures glycemia. What biomarker would you use to measure kind of, the greater concept, or does the biomarker exist? Like if you had to say, what is the most readily available biomarker that you would use beyond hemoglobin A1C?
Yeah. So first of all, very simple one, body weight, and these kind of things. But if you really like to see now regarding my bias, which is inflammation, then the very simple CRP is extremely reliable, at least for what is occurring systemically. So, I mean, for the cardiovascular, and it's really very sensitive. And it's even typically we say starting with a CRP of 2 milligrams, it's already pathological. But if you look at patients losing weight, you see that they may have been before losing weight 1.8 and then go to 0.7. So it's a very, very sensitive. And then there is a bunch of, like IL-6 is an easy one to follow up. But if I may say something on IL-6 is often seen as also a possible target for cardiovascular and metabolic disease. But I think that there is a lot of evidence to say that it is not for that. For question of time, I will not develop on that. But just to say one example, IL-6 stimulates GLP-1, and I think it's a mistake to antagonize IL-6 if you want to achieve cardio-metabolic improvements. It's a small part, but it's still the biomarker of this increased inflammation. And then you have also IL-1 receptor antagonists. These are the three that I will use. Another very simple one is also the neutrophils. And each time we antagonize the IL-1 system, we see also a decrease in neutrophils. So they are not pathologically elevated, they're slightly elevated and go down. And then if you can afford, the best one is you take monocytes and you do RNA sequencing, and then you have the whole picture.
I have a clinical question regarding these new drugs, the IL-1RA and so on, and the antibodies and the anti-NLRP3. With all the drugs we have now for diabetes to lower glucose, where would these fit in in terms of complications? At what point would you say that they might be of use to add on?
Yeah, I think they come probably later on. So when you start to have the complication of diabetes, we know that the more advanced the diabetes is, the less important a stringent H1C is, because there you have the tissue complication, and also because I spoke a lot about glucose, but we know that fats, cholesterol, and so on, all of that are also toxic. And there, on top of the different drugs, there is still room to improvement, and there is where we would see so in a patient with already CKD or these kind of complications.
And you mentioned increased infection in some subjects with cancer. What about in people with complications? In the long term, would you risk more infections?
That is a surprising part, that if you only antagonize the IL-1 system unless you have a really severe infection, the IL-1 system seems not to be so important to fight infection. And there are other parts of the immune system. And I really believe that the IL-1 system here is to regulate nutrient into the immune system. Again, for question of time, it didn't show that, but the immune cells are directly activated also by cell nutrient, and they have other program depending on nutrient. And in all that, the IL-1 system plays a role, but not so much in defending against microorganisms.
We have a question in the chat regarding lifestyle and exercise, which are anti-inflammatory and lower glucose, from Dr. Dasgupta. Do you want to comment on exercise?
Yeah, so it's an interesting thing. So I hope I made my point clear that inflammation is not only bad, it depends on how much and so on. I'm saying that because if you exercise, one of the things which happens is that the contracting muscle will produce in a physiological way IL-6, and this IL-6 will then regulate fat repartition and also induce the insulin that you need after exercise in order to have increased meal and so on. So you have an acutely more inflammation, but chronically you have less inflammation. Why do you have chronically less inflammation? It's speculative. It could be simply because you're having healthier metabolism and less metabolic stress. All the time, when you look at the effect of GLP-1 analogs, of exercise, you always have the confounding factors that you're losing weight, and therefore you don't know, is it because you directly modulate with exercise the immune system, or is it because you have better metabolism and therefore you have a better less inflammation? But in the long run, you have less inflammation with exercise.
Another question from Dr. Sharma, great talk. He asks if there are any sex differences in the inflammasome or inflammasome response.
That's a very interesting and difficult questions. What is clear is that several hormones, estrogens, testosterone, and so on, act differently on the immune system. But to really tackle this question, I couldn't answer to you. It's also interesting to see that during pregnancy, you have a much exaggerated inflammation, the deleterious inflammation, so CRP is increasing and decreasing after, all of that kind of things. So the answer is clearly yes, but it's more work to do.
Okay, thank you. Sasha Bernatsky asks, my RA and SLE patients without diabetes are often asking about diet. Do you have any insights on how diet or other lifestyle habits like intermittent fasting or exercise impact the inflammasome?
Yeah, so clearly if the patient with RA or any other immune disease are obese, lifestyle intervention will improve their disease. And there is, the best is in psoriasis, the best shown there. If you have psoriasis and you improve your lifestyle, that improve. Now, how to do that is like lifestyle intervention. There are a lot of hypotheses, and which one is the best one: intermittent fasting, exercising, eating in the morning, eating in the evening. The only thing which convinced me is if you have less calorie input and more burning calories, then you improve. And everything else, I think, is still a little bit speculative.
We have a question from Dr. Mitchell. A very interesting talk. You spoke about glucose toxicity. Could you comment on the role of toxic fats like sphingolipids and ceramides as targets for diabetes or complications?
Yeah, so they're clearly also targets, and it's just for question of time, and also because of my bias, because I worked more on glucose, but clearly the lipids are also drivers of this pathway, and there is much more to look there. The only caveat when it comes to lipid is that sometimes people do not realize that a lot of time with lipid you have also LPS coming alone, so it's sometimes difficult, and you have to be very, that's more from experimental point of view, very careful to have LPS-free lipids. But from a physiological part of way, I'm sure that part of the inflammation is driven by bacterial products which comes with the fat and then goes to the fat deposit, and from there they are coming out, and you have increased LPS levels in patients with obesity and type 2 diabetes.
Thanks. One more question from Kaberi about the post-bariatric surgery study. Why did you select SGLT2 rather than any other glucose-lowering medication if the goal was to reduce postprandial glucose?
Yeah, so the question is a little bit which one. So because we wouldn't like to take another glucose-lowering agent like sulfonylurea, because then we would have even more of this postprandial hyperinsulinemia. Okay. So by giving SGLT2 inhibitor, we prevent the glucose-induced insulin, and that's the reason why we choose SGLT2 inhibitors.
By the way, is the IL-1 beta, is that why is it higher post-gastric bypass? Is there more of a response? Or?
Yeah, that's a good question. So first of all, we believe it is because you have this stronger postprandial glucose, and then you have a stronger IL-1 beta. But could be also because of the change of the anatomy, that you have more change in microorganism, and that more glucose goes to the bacteria, and there you have a little bit more of translocation of bacterial products driving IL-1.
Mm-hmm. So is the serum IL-1 beta that goes up after eating, is that coming from the immune cells or all cells? You showed the beta cell.
Yeah. So that's an important point that you say. It was our initial work which made us believe that IL-1 comes from the beta cell. In the meantime, we believe that there is a little bit of IL-1 beta coming from the beta cell, but the major one is from macrophages. Just at that time, it was a dogma that there is no macrophage in islets, and only later we observed that there are some macrophages in the islets. So the short response to you, I think the main source of IL-1 beta all over the body is our monocytes or macrophage.
Great. Okay, well, before we close, I'd like to thank Novo Nordisk once again. Fantastic lecture, Mark. Thank you very much. I think you've highlighted the importance of inflammation in diabetes, both causing diabetes as well as in the complications of diabetes. And of course, it spreads to the nephrologists and the cardiologists. So thank you so much. And Nadia, would you like to close the rounds? Thank you, everybody, for attending.